Hello friends, welcome back to my channel Medicine Hub 101. Today we'll talk about ovarian hyperstimulation syndrome. So it's one of the important topic regarding gynecology. Okay, so let's start the topic. So from the term, it's quite easy to understand. Ovarian hyperstimulation syndrome. That means the ovary that will be hyperactivated and that will secrete more amount of the hormones. Right? Now see, before starting the topic, let's have a little idea about IVF, in vitro fertilizations. Now see, during in vitro fertilizations, what we do basically, we give the injections of FSH. Injection of FSH. So see, whenever we are giving the injection of FSH, normally our body produces from the anterior pituitary, as we know, the FSH is coming. Now, the amount we will give that near about 10 to 12 times than the normal productions of our body. Now, whenever we will give 10 to 12 times of the normal value of the FSH that is produced by the pituitary, and as a result we will get the productions of the more number of the follicles, right? So for example, I am taking the ovary over here and I'll get, for example, okay, let's change this one. Okay. So for examples, we are producing 15 eggs, because in vitro fertilizations, as you know, each of the follicles they will be able to produce the ovum. Okay. Now, as you know that each ovum or each follicles over here, they are able to produce near about 200 picogram of estrogen. Now, if each egg produce 200 picogram of estrogen, so how much estrogens we are getting from here? We will get around 3000 picogram or picogram, whatever you can say, right? Now, for example, the woman who has come to PT and he's having the problem in infertility, and she's having some problem. For example, she's having polycystic ovarian disease, or she's having some drug problems or drug toxicity. For what? We are getting to see over here. We are getting the same injections, but in this cases, the woman, she is producing, for example, in these cases, the woman, she is producing, for example, 40 eggs. Now, whenever we get to see the 40 eggs or 15 eggs is produced, and each of the follicle is having the same capacity to produce the same amount of estrogen. So, in these cases, we'll get we'll also get to see 200 picogram of the estrogen. As a result, we'll get 8000 picogram of the estrogen. Is the estrogen. Now, there is a range. Whenever we get to see the productions of the estrogen, the estrogen production that will be more than 3500 picogram. At that time, this estrogen that can activate some problem, whatever the problem, that can activate or that can trigger to produce the vascular endothelial growth factor. It is also able to produce or activate the renin and prorenin. It is also it can also activate the angiotensin. Right. Now see, all of these factors for the high productions of the estrogens, we are getting to see these factors are getting produced or these factors are getting activated. And whenever this will be activated, what are the thing we'll get to see? Here we'll get to see the vascular permeability. The vascular permeability that will be increased too much. And whenever we will get to see the vascular permeability that will be increased too much, what do we know? Normally the fluid from the intravascular system, that will come to the third space in the interstitial space, right? So for example, the fluid from the intravascular system that will come out. So whenever the fluid that will come out in the third space, so basically we'll get to see over here the shift of the fluid or fluid shift from the intravascular space to the third space. So we can say over here, as a result, we will get to see that the fluid shift from intravascular space to third space. And whenever the fluid that will be accumulated within the third space, whatever the manifestations we can get. So within the third space, we can mention over here, whenever the fluid that will be accumulated within the peritoneum, for example, that will leads to what? Ascites. Whenever the fluid that will be accumulated within the lungs, especially within the pleura, that will cause the pleural effusion. Whenever the fluid that will be accumulated within the what? Pericardium, so that will cause the pericardial effusions. Or normally it can also produce the edema. It can also, it can also manifest as the edema. So whenever it will be produced or accumulated within the peritoneum, it will show the ascites. It can also show the pleural effusion. It can also show the pericardial effusion. And it can also show the edema. Now whenever we'll get to see this type of thing, the patient can die also. See how? See, whenever we get to see the pleural effusions, right? So, or we can say also the pericardial effusions or the ascites. First, if we talk about the ascites, now see, ascites means what? The fluid is accumulated within the abdominal regions, peritoneum. Now see, whenever normally what do we know? Whenever we are just doing the inspiration, the diaphragm that goes inward, right? Now, whenever there is ascites, so the fluid, the diaphragm that will be not able to go inward because the fluid is accumulated over here. As a result, we will get to see the what? The breathlessness, or you can get the shortness of the breath, just like this. Okay. So for this thing, we can get to see the breathing problem. We can get to see the breathing problem. As a result, we can get to see the respiratory distress syndrome or respiratory distress. Okay. Now see, if we talk about the pleural effusion, the pleural effusions, the pleural, the lungs that will be not able to expand properly. As a result, we can see also over here the cardiac output that will also drop dramatically. So in these cases, if we see that the cardiac output that will also drop dramatically, and the pericardial effusions, we can get to see the different kinds of the problem. The pain within the chest. And edema, I think you know it about the edema. I'm right now I'm not explaining. I have already uploaded the videos basically on the particularly on the edema, whatever the edema, the extravascular, intravascular, all the intercellular, extracellular, just like now. If we get to see this type of thing, the patient even can die. That's the problem. Okay. Now see, another important thing, whenever the fluid that is coming out from the intravascular system, from the intravascular space to the third space, whenever we are getting the fluid shift from the intravascular space to the third space, within the intravascular system, within the intravascular area, the blood that will be more hemoconcentrated. So we'll get to see over here, in these cases we'll get hemoconcentration that will be increased. Normal, what do you know? Normally the paxil volume, how much? Near about 33. And if we divide 33 by 3, if we just divide the paxil volume by 3, then you get to see what? We will get the hemoglobin level. Now if we divide 33 by 3, we will get 11. So 11 is the hemoglobin level over here. Okay. But in these cases, that means in these cases, I mean in terms of the fluid shift from the intravascular space to the third space. In these cases, we will get to see the paxil volume. In these cases, for example, over here I am showing. In these cases, the paxil volume that will be more than, for example, 45. So whenever we get to see the paxil volume that will be more than 45, this will cause. Try to understand from here. More concentrated blood or fluid, whatever you can say. So you get to see these things. Now another important thing see over here, that basically our main target was to have the what? To have the fetus, to have the children. Now in these cases, whenever we're using the FSH, as a result we're getting the productions of the follicles, as a result we're getting the productions of the estrogen. Alright. Now normally what do we know that LH, under normal circumstances what do we know that LH, the LH that LH cells that cause the rupture of the follicle, and that we get the ovulation, means we get the ovum normally, right? Now in these cases in the in vitro fertilization process, we usually what, give the HCG injection, human chorionic gonadotropin injection. Yes. So whenever we are injecting the HCG, see these HCG injections that will trigger these factors, that will trigger what, this one, the renin, prorenin, whatever I have written over here, the same thing, and angiotensin, that will trigger this factor. As a result, the conditions will be so worst. Conditions will be so worst. I mean, see, normally what do we know? Normally, whenever the implantation is done, for example, then what do we know that the HCG productions will be started from the cytotrophoblast, syncytotrophoblast. Now, the HCG we are injecting the HCG, and we are also getting the HCG from what? From the syncytotrophoblast. As a result, we get to see in these cases the productions of the HCG that will be too much. The problem will be so severe in these cases. Okay. Okay. Now, see, another important thing. See, whenever as I said over here, that whenever the blood that will be hemoconcentrated, whenever the blood, the hemoconcentration that will be increased, hemoconcentration that will be increased. In these cases, we get to see that the chances for the development of the thromboembolic phenomenon that will be increased. What did I say? Whenever the blood within the intravascular area, the blood that will be hemoconcentrated, at that time the chances to develop the thromboembolisms that will be increased, right? So in these cases, we will get to see the chances for the thromboembolism that will be increased. And whenever the thromboembolism that will be increased, basically we get to see where? We get to see within the kidney, renal thromboembolism we can get to see, we can get to see the cerebral, we can get to see the hepatic thromboembolism in this case, or we can get to see in the limb, the upper limb, lower limb, basically in the lower limb. Now see, in these cases we can get to see the thromboembolisms, and you know already that whenever we get to see the thromboembolisms, that will obstruct that what the blood vessels, and the blood the blood flow will be inhibited within the particular regions, and we'll get to see the development of the ischemia, and ultimately we can get to see that multiple organ failure, and this can also cause the die. There's a problem over here, right? Now we have to go for the management, right? See, basically the main thing is over here, where our good intentions to have by using the in vitro fertilizations, we used to have the baby, under normal circumstances. But in these cases, if the woman is having some problem, for example, the polycystic kidney ovarian disease or the drug problems, and whenever she is having this type of problem, then there will be this type of the manifestations. The too much amount of the estrogen that will induce these factors, ultimately will get these complications, right? Okay. Now we'll classify. There are some there are some types. There are some types. See, the types on the basis of what? See, whenever we are getting the amount of the follicles, is getting increased, of course the size of the ovary that will be increased. What did I say? Whenever this size increase, that means the size of the ovary, sorry, I'm so sorry. Size of the ovary that will be also increased. Now see, whenever the size of the ovary that will be increased, so what type of problem we can get to see? Whenever the size of the ovary that is getting increased, so we can get to see the torsions, we can get to see the rupture of the ovary, or we can get to see the hemorrhage over here. See, so So whenever the size of the ovary is getting increased, we can get to see the torsion, the rupture, or you can get to see the hemorrhage over here also, right? Normally, what do we know? Normally, the size of the ovary is 3.5 multiplied 3 centimeter. This is a normal size. Now, on the basis of that, the size of the ovary in vitro fertilization, Dr. Mathur, what did I say, Dr. Mathur? Dr. Mathur classify the three types, rather I should say four types. Okay, Dr. Mathur, so four types. So what are the types? First, I am writing over here the type. Type 1, type 2, rather I should write on the basis of the different thing: mild, moderate, severe, and critical. These are the types on the basis of the size of the ovary, right? Now see, whenever in the mild, in terms of the mild, the size of the ovary, that will be less than 8 centimeter, and it in these cases we will not get that much kind of the manifestations. In these cases we will not even get to see the ascites. So we can say over here no ascites. I'm just taking the hypothetically, I'm just taking for measurement of the size of the ovary in terms of the manifestations. Okay. Now moderate, in terms of the moderate, we will get to see the size that will be from 8 to 12 centimeters, and in these cases we will get to see the ascites, but on ultrasound. Okay. So basically we will get USG ascites. The third one, in terms of the severe, 1 minute. Okay. In terms of the severe, whenever the size that will be more than 12 centimeter, in these cases we will get to see that the clinical ascites. On clinical examinations, we can get to see, yes, the woman is having ascites. So here we can write that we will get to see the clinical ascites. And the severe one, whenever the size that will be more than, for example, 15 or something like this, in these critical conditions we get to see the tension ascites. Okay. Among these four types, in severe and in the critical types, the pregnancy should not be what, under process. That means in these two conditions, because there is a chance for the death of the bad conditions of the woman. So in these two conditions, in the severe and the critical conditions, we should not plan for the pregnancy. So in these cases, I will write simply no pregnancy in these two conditions, right? And in mild and moderate, we can continue for the pregnancy, because in these two cases we will not get to see that much severe problem over here. Okay. Now let's go for the treatment part. So how can we manage the patient? Where is this? Wait 1 minute. Wait, okay. So how can we manage this patient? So management. The first thing, if we get to see that under these two stages, I mean the severe and the critical conditions, in these two conditions, I should say in the 3 and 4 conditions, no pregnancy. Then we can remove the fluid, as we are getting the accumulations of the fluid, so we can remove the remove fluid. After that, we can use some intravenous fluid, IV fluid, and as we are getting from the intravascular area, the intravascular space, the fluid is coming out. That means within the intravascular space, the fluids are not able to held by anything. So that's why That's why in these cases we can use some NaCl crystal, sodium chloride crystal. We can use some dextrose for the fluid, remove the fluid. Okay, and apart from that, just to hold the water, just to hold the fluid, properly, we have to use albumin in terms of the colloid. We can use the dextran. We can use the starch, because these things are having the capacity to hold the water molecules or to hold the fluid together. As a result, we will not get to see the development of the fluid accumulations within the third space. So this was all about that ovarian, hyper ovarian, or sorry, we should say the ovarian hyperstimulation syndrome. Ovarian hyperstimulation syndrome. In the next part, we'll talk about the test of the ovulations. Okay, that is a very short video. So, continuing just like this, we'll try to cover the gynecology. Please be with me, and if you are new in this channel, please don't forget to subscribe my channel and please support me with the next videos. Thank you very much.